Should I admit everyone else then, or do you want
Yeah,
a minute
yeah,
before?
just a minute with Soumitra.
Sure.
Soumitra, can you switch on your video, or is that
Anand, I can't hear you. I don't know if others can hear you.
no? Can others hear me?
Can you hear me, Anand?
I can hear you.
Yes,
Yes.
Anand sir, we can hear you.
Yes. Soumitra, we can hear you.
I
Can you
can
hear us?
neither hear you nor see you.
No, Soumitra, yes, we can't hear or see yet.
I can't hear him. I can't see him either.
Yeah, exactly.
He's still muted.
Yes.
Why is he muted?
I can hear you now.
Oh, say something. I can't see you.
Can you see me? Hold on a second.
No, we can't see you
I'm
yet.
having all kinds of problems here.
Now we can see you. Great.
Yeah,
All right.
yeah.
Okay, so I think we are all. Should we get started? Because I think we're already 2 minutes past the.
Yeah.
Yeah. And so I did
I
tell.
still can't see from it.
Oh, why is that?
I can't
No,
see
he
you.
can be-
It's just a big black space.
Oh. Okay.
I can see you now.
Yeah,
I can see you now.
All right. Okay.
Yeah.
Great. And we have everyone else admitted as well, Udita?
No, Anant, I'll admit them now.
Yes, please. Go ahead.
64 people.
Yeah, admit.
Not
admitted.
bad.
Not bad. I told him, you're the kind of Zoom king. They're all they're all signed in to see you.
They
that.
get to
Zoom
see me
king.
thousands of times. They have out here to have darshan of you, who is the rare one to find. So
This is being streamed live on YouTube. So all of these comments are being live.
that's okay. That's okay.
No, but I think we must recognize that Soumitra is the Zoom king. So it is.
All right. That's a
Oh,
good
Vikram
pretext
also
to
joined.
use. Yes. All right. I think we should get started. Yeah.
Yeah.
Okay. Hi, good evening, everyone, and welcome to the Policymaker Engagement Series webinar. This is the 5th of our series, and we are delighted to have Mr. Keshav Desiraju and Soumitra Pathare join us in this particular iteration. This particular webinar is also a collaboration between Sangat and the Center for Mental Health Law and Policy. And we are delighted to again, be collaborating with a group we have a lot of obviously close collaborations with in multiple domains in mental health. So just quickly about Sangat. Sangat is an NGO committed to improving health across the lifespan by empowering existing community resources to provide appropriate physical, psychological, and social therapies. The primary focus areas include child development, adolescent and youth health, and mental health and chronic disease. Essence is a 5-year research project which is funded by the US National Institute of Mental Health, aiming to bridge the gap between science and mental health care services, and also seeking to generate evidence on cost-effective implementation approaches for scaling up of evidence-based interventions for mental disorders. As a part of Essence, we have a capacity building component under which we are hosting this webinar series. We are also, as I said, delighted to be working with the Center for Mental Health Law and Policy at Indian Law Society, Pune, which aims to protect and promote the rights of persons with psychosocial disabilities using a rights-based approach to mental health. And the center's work is spread across law and policy reform, suicide prevention, community-based mental health interventions, health system strengthening and institutional reform, peer support, youth mental health, and training and education. Just some ground rules, as always, for the webinar. Please keep yourself on mute throughout the session and ideally keep your video off. You can ask questions in the chat window, and if you're following on YouTube, you can also ask your questions through comments there. The moderator from our team will collate the questions and ask the two speakers on behalf of the participants once they are finished with their initial introductory remarks. Any rude or inappropriate questions obviously will lead to the participant being removed from the webinar. And policymakers who are participating in these series are speaking in their individual capacity, and their views might not represent those of the government. If any of you would like to have a participation certificate, kindly get in touch with Babita from the Sangat team. This is our email ID, and you can indicate that you registered and you will get that e-certificate. Just also to flag that our probable next webinar is going to be on the 24th of November with Dr. Rajni Ved from the National Health Systems Resource Center. And she will be speaking on situating mental health within comprehensive primary healthcare reforms in India. So that's almost a month from now, and you will receive more information. You can also get that information from our social media channels. So very quickly, just introducing our speakers. Dr. Soumitra Pathare is a consultant psychiatrist and director of the Center for Mental Health Law and Policy at ILS Pune. His primary interests are in the area of mental health policy, scaling up mental health services, as well as rights-based care and legislation. He has provided technical assistance to the Ministry of Health and Family Welfare in drafting India's new Mental Health Care Act of 2017, which takes a rights-based approach to mental health care and provides for publicly funded universal mental health care. He's been also serving on multiple policy groups, as well as has been a consultant with the WHO in helping them in drafting and implementing mental health legislation and national mental health policies. Mr. Keshav Desiraju, also we are delighted is joining us today, has retired from a career within the Indian Administrative Service, and in 2013 was the Secretary of the Ministry of Health and Family Welfare in the Government of India. And it was during his term that a lot of the progress within the mental health legislations that we talked about happened. He also presently continues to remain engaged with issues in public health, particularly mental illness and mental health, primary health care and community health, and serves on the board of several non-profit organizations in the sector. So thank you both, Keshav and Soumitra, for agreeing to speak. The plan is for Soumitra and Keshav to have a conversation for the next 40-45 minutes or so, and then we will dive into the moderated Q&A, and I will help Keshav and Soumitra in directing questions to them by keeping a watch on the chat function. So once again, thank you everyone for joining, and over to you, Keshav and Soumitra.
Thank you.
Yeah, hi, good evening, everyone. Thank you, Anand, for that introduction and for this invitation. The way we are going to do it is we're going to have some questions which I will ask Mr. Desiraju. But before we go to that, just to give people an idea of where all of this is situated, because I was told that many people may not have a framework into which to put mental health policy or mental health law, because it's just seen as some of these esoteric topics that clinicians don't really engage in. The thing is that we've never actually had a national mental health policy. We've had health policies, and which would carry a couple of lines on mental health, but we've never had a national mental health policy until 2014, when the first national mental health policy was released by the then health minister, who also incidentally is the current health minister. This is very, and we've had mental health law, which was until 1980s, the law of 87, which was around, and for which there were lots of criticisms why it was not good, and I'm not going to get into that. And so there was always a need for wanting to replace that law. And so policy and law need to go hand in hand. We've had a very unusual situation where we've had a district mental health program, which is actually the services, in place for more than 25-30 years. But we've never had a proper policy, and we've never had a proper legislation. Or we had a legislation, but the legislation was not in sync with the services. So, you need to think of policy, law, services as three parts of the same structure, and you can't just have one there without the other. And so the attempt in 2013, 2014 was to try and do all of this together. So one of the things that was done under Mr. Desiraju's guidance at that time was the DMHP was reviewed and it was repurposed to some extent. And so after 2014, there has been a slight change in the DMHP. And then obviously trying to put a policy in place and put a law in place. And the idea was to ensure that the law, policy, and the DMHP tried to run in sync and in sync with the disability sector and the Ministry of Social Justice. And that was a broad conceptual plan of trying to fit these pieces together. So that's just to give everyone an idea of how it works. I remember Joe Chopra. Many of you probably know Joe Chopra, but Joe runs a wonderful NGO called the Latika Roy Foundation in Uttarakhand. And Joe Chopra said in 2012, if I'm not mistaken, or 2011, when Mr. Desi Raju was appointed the secretary, that mental health hit it lucky. And over the next 1.5 years, it did actually prove that we did hit lucky, because I think we managed to get a lot of stuff done while he was the secretary in the Ministry of Health and Family Welfare. So I'm not going to waste more time. I'm sure you are keen to listen to him. I'm going to throw the first question at him, which is, if somebody came to meet you when you're the secretary, and if one of these, I'm sure there's a lot of researchers and clinicians around here who kind of feel that they should have policy engagement or policy impact. That's what clinicians think. We should have policy impact, and we have a whole bunch of research we've done. Why doesn't anyone listen to our research? And maybe we should go and talk to the policymaker. And you were a policymaker, so when somebody comes to meet you like that, how do they get your attention in 5 minutes? Because probably you're not going to see them for more than 15 minutes. What do you expect them to say in the first 5 minutes, which will mean that you will now start listening to them and not look at your phone or your email or call the office boy to deliver some files? What do they have to do?
Well, that's actually a trick question. Um, but I think what would strike me the most is whether I get a sense that this person knows what she is talking about. It's very easy to tell when somebody is waffling or when somebody just, is trying to make an impression. It's also easy to tell when somebody knows their subject. And I think that would be important. So if I were to get a sense that, look, it's worthwhile spending some time talking to this person because this person clearly knows what she's talking about, I think that would be it. That would be it.
But very often, I mean, you said about the knowledgeable thing, and I know that people are knowledgeable. People who are academics or people who've done research for many years are very knowledgeable. And sometimes I think the paradox of it is that you know so much that you don't know how you're going to summarize that into that 5 minute or 2 second elevator or 30-second elevator pitch to get your attention.
It's also possible to tell which of these people, assuming that they all know a good deal, there are some people who also convey the fact that they know how their knowledge can be used. And the fact that they're interested in impacting policy also tells me something, that they have a sense of what is happening in the field. They have a sense that everything that they and their fellow researchers and fellow clinicians, what they know is not really being translated in any way into effective action, and that bothers them. They're able to communicate that and convey that. It's quite easy to tell the difference between somebody who sees these linkages and somebody very knowledgeable doesn't see these linkages. It's possible. It's possible.
And when you had people come in to see you, and I've sat in your office at times to see the stream of people who'd keep on coming in with basically, it was a little bit like everyone coming in with a request, darkhas, can you do this for me? Can you do that for me? How often do you find that when you get academics and researchers come, that they actually come to you with requests for specific things versus a request or a discussion about the broader policy agenda? I mean, what are the kind of tips you will give to young people around here, saying, look, when
Well,
you're engaging in with a policymaker, remember these things?
Well, the first thing I've already said. Remember, please make absolutely sure that you know your stuff. You
That's
know
right.
what your ask is. You know why it's not happening. You should not be in a position where you can be challenged on something. So if, for instance, if somebody came to see me saying, I work as a psychiatrist in the government system, and this is what is wrong with DMHP in my district, and knows all of, I mean, I would take that person seriously, because here there's a person who knows the subjects, who knows the field, who has some experience of working with a program, and this is someone to be taken seriously. I think it comes back to that. You should know your stuff before you want to engage in discussions of this sort.
Right. I mean, I have only two, kind of principles, or you can say formulae, when I'm dealing with policymakers, which I'm sure you are fully aware of, is one is, I don't presume that the policymaker is not a smart person. I actually presume they're very smart people, because getting into my logic is getting into IAS is harder than getting into a medical school, if you actually look at
It's not as simple as that, but then, okay.
So if somebody's managed to get into the IAS or any of the civil services, then clearly they are smarter than me, who went to medical school, because it was far easier to get into medical school. So
that's not actually true. That's not actually true. I think you can find a lot of smart people who don't actually know how to use their smartness when they come into a position of authority, and that's very sad. No, but you ask me, how would you react to an academic or a researcher who comes in with a question? Uh, sometimes people who are not academics, I think one should, when one sits in a chair like that, in any position in government, really, even when one is very young in service and very junior positions, I mean, you should be able to figure out when somebody really has a genuine problem. And I remember this very well. For instance, there are one area of health policy and health programming where actually India's record is really shameful, is how our whole system for coping with congenital disorders, sometimes which affect a very small number of infants, but which is obviously the biggest, most important thing in the lives of the parents of those infants. I do remember on two occasions, there are support groups of parents in situations like this. And I remember this gentleman who came in, struggling with trying to get essential medication for his small child, trying to get it through customs. And it was just an absurd matter. It was the way in which it had been complicated. But then this man clearly had a problem. And I think anybody who works in government and people who work in positions where, there's a great deal you need to do, but I think you should be able to figure out, is this person genuine? Is there a problem here? And this guy, it was clear to me, nobody was listening to him. Nobody was listening to him because there was no lobby. It was just his problem and the problem of other parents in situations similar to his, the very handful of children across the country suffering from that disease. He was not even asking for money. He was not asking for free medication. He just wanted permission to clear his medication through customs. We actually got some rules put in place after that, which made life simpler. So I think that's also important to know. That is also something I would regard as an actual real life change to how a policy was implemented or a program was implemented. And it happened because somebody who had a genuine problem not only came in to see me, but was able to convey the seriousness of his problem. I think that's also important.
I think you made a very important point there, that not only did you address his problem, but you also addressed the systemic issue in it, because you made a policy for it. And I think, unfortunately, very often what happens is that does not happen, that the systemic problem continues to remain while you solve the individual problem.
Individuals, unfortunately, are still very important in anything that involves government in India. Systems don't work. The fact that, and I expect we will come to that in due course when we talk about the mental health policy in India, how having a policy in place really is only the first stage. There are many, many stages after that. And it's an essential first stage, but that's all it is. You can't go to the second stage without having the first stage. But the first stage in itself is doing nothing for you. I think that is sadly true of policy in many development sectors in India.
Well, I mean, since you raised this issue, I was in fact going to move to that question, is, well, what do you think in terms of policy? The national mental health policy gets talked about. It comes up repeatedly in, we've got a policy, we're doing X, Y, Z. And I do know that we put in a lot of effort on that policy. And Vikram, who's here, was part of the group along with me and others. And we had a good representative group, and we really deliberated the policy. It's a decent enough policy. What do you think has gone wrong with the fact that it has, for all practical purposes, remained on the shelf? It hasn't really seen action based on that policy. It hasn't, so there is a policy, it talks about doing XYZ, but not even half of X has started off.
Well, you're right. It's a good document in there. It's a very good text, and as you know, it was substantially the basis also of the resolution adopted by the World Health Assembly in 2012 on the global mental health policy that WHO adopted. Uh, it was a resolution that India had sponsored. I think that why does policy get neglected? Uh, there are not enough people interested enough in it to push it. Well, you see, there are the big health policy, health programming in India.
We seem to have lost you for a minute. Anant, can you hear Mr. Desiraju? I can't.
No. I think there might be a connectivity issue. So why don't you maybe provide some of your insights while Keshav is joining?
Yeah, I'll just wait. Well, let's wait for 2 minutes or 2 seconds or so, and if he can join, then good. Otherwise, is he disconnected now, or he's still on?
I'll just check.
It's very difficult to work out if
Sobita is still on.
Yeah, he's still there, is it, or he's disconnected?
He's there.
Oh, he's there. Okay, so maybe we need to tell him we can't hear him because there he is. I saw him.
Yeah, but he's on mute.
You're on mute now. You need to unmute yourself.
Is that better? Can you hear me? I'm unmuted now.
Yes, we can hear you. Please go ahead.
Hello. Yeah. So I was saying, health policy is still, in some senses, driven by communicable disease, by maternal and child health. That's where the big money is. And even in non-communicable disease, there's the National Cancer Program. Mental health simply has not been able to pull its weight in the priority setting, budget setting processes. So, and this is linked to what I was saying earlier about systems not working. In an ideal system, the fact that there was a good policy adopted by the government in place should automatically, without anyone's intervention, it should have led to a situation where somebody asked the question, what does this implementation of this policy require in terms of budgetary support or anything else? Those questions are not being asked because the announcement of the policy was seen entirely as an end in itself. You will recall how suddenly out of nowhere and early in October in 2014, somebody said, oh my God, 10th October is World Mental Health Day. We must do something. And then some other person said, there's a draft policy which is done and sitting somewhere. And then a third person said, yeah, let's announce it. And because that was the objective of the exercise, it was announced on 10th of October to wild applause. But then clearly there was no motivation or no correct motivation in that process. So nobody asked the follow-up questions. Okay, so now what does that policy enjoin upon us to do? And can we do it? And is there the money to do it? And all the other questions about are we training enough health professionals in the mental illness area to be able to cope with this? This is by no means a new situation. You mentioned the district mental health program earlier, which came in 1976, if I remember correctly. And the original DMHP documents talk about how every district where DMHP is implemented should have a psychiatrist,
Keshav, I think we've lost you again. Soumitra, are
Yeah.
you still around?
Yeah, I'm still around. I'm listening. I mean, I can jump in if, like, before we don't get him back
Yeah,
in.
listen, can you hear me
Uh,
now?
yeah, we
Can
can
you
hear
hear
you
me
now.
now?
Yeah, we can hear you very
Yeah,
well now.
I'm not sure when you lost me, but I was saying the DMHP, which
Yes,
we've
you were
had
at the
since
end.
1976. Hello,
Yeah, we can
can
hear
you
you.
hear me now?
Yeah.
Yeah, I was told, I'm not sure whether you heard me on DMHP, but I will repeat myself that DMHP requires every district to have 4 mental health professionals: a psychiatrist, a psychiatric nurse, a clinical psychologist, and a psychiatric social worker. We all know that these people don't exist. The numbers don't add up. If someone does the exercise, how many psychiatric nurses are we training in India? And where are they? And are they present in the DMHP districts? The answer is no to all this. However, we continue just to pretend. So this is what has happened to the mental health policy also, that we just having the policy is somehow seen as an achievement in itself, and that good things will happen and mental illness will be taken care of. So this situation, I think, I mean, who are the people who get things done in our system? It has to be either parliamentarians, it has to be civil servants, or it has to be civil society activists, or it could be the courts. But the difficulty about the courts is things will happen only as long as the court is monitoring something. But so if parliamentarians are not showing any particular interest in getting the policy implemented, if civil servants and the health ministry are not showing enough interest, and this includes state governments as well, and if the courts are not involved, then clearly it is now incumbent upon civil society activists to try and do something, saying that there is a policy which this government has adopted, there is a law, both the policy and the law are much commended. Now do something. This has happened. I mean, I can think of this has happened quite successfully in tobacco control, for instance, where the intervention of the courts has on more than one occasion proved very decisive. But something of this nature needs to happen.
Yeah, I mean,
Uh,
I kind of agree with you when you say this about civil society involvement, because one of the things that has always struck me is, even with the Mental Health Care Act, for example, we have the advanced directives in the Mental Health Care Act. And the act came into force in 2017, and we still haven't put procedures in place for implementing the advanced directives. But interestingly, in the common cause PIL, which, as you said, the courts got involved, and the court said, well, we should allow passive euthanasia, and that judgment is only from 2018 or 19. And it's interesting because in that judgment, they said, relying on the Mental Health Care Act, which made
yeah,
provisions for advanced directives, we are going to frame a set of advanced directives for end of
yeah.
life care and for passive euthanasia. And
Mm.
so they made, and it's substantially, they just copied out what was in the Mental Health Care Act, but added some more protections because it was a matter of life and death. Now, interestingly enough, the palliative care movement and the end of life care movement have run with it very well. So that the living will, you hear about workshops happening, guidelines have come out for it. Civil society is aware of how to register it. So that has all happened. And you can actually now register a living will for passive euthanasia, but you still don't have a situation where you could register an advanced directive for mental health care, which actually brought that other thing into it. So, I wonder what happens there.
I, I would not. I have not really given up hope on that front, because on both the practice and use of advanced directives and the practice and use of nominated representatives, both of which the Act provides for, I think this will happen. This will happen through court practice and precedent. Sooner, later, if not sooner, somebody is going to go to court saying, I have written, so and so has written an AD, and I am the guardian, I disagree with it. I'm sure these things will come up before court, and it is through court precedent and court orders that the jurisprudence around the use of advanced directives and nominated representatives will settle. So that might take some time, but I believe it will happen. And if there is no procedure laid down, it's quite possible somebody will go to court saying there is no procedure, please direct that a procedure is put in place. So that will happen then. So while it is possible that our mental health policy document will simply languish for want of attention, the Mental Health Care Act, I'm a little more positive about, only because I think as and when people start taking provisions of that act to court, they will grow around it a certain body of jurisprudence, which in the long term will help the act to settle.
Well, I'm glad you say that and you're optimistic, because I'm kind of tearing my hair out, at least on the most obvious thing in the Mental Health Care Act was the provision of insurance. Removing the exclusion of mental illness from health insurance, and which is the easiest and the simplest thing. It's very specific, and the IRDA was supposed to have done it like 3 years ago. And the IRDA has been dragging its feet. And I hear civil society complain and moan and groan about it, but I haven't actually seen any action.
Well, when I'm said I'm optimistic, I'm guardedly optimistic. It depends on the court. Somebody has to go to court and work it through. And there are some people like this who know how to appeal to the courts. And specifically on the matter of insurance, I'm sure a time will come when somebody very wealthy or very well placed needs this act to work in his favor, and then things will start happening. Unfortunately, that's the way things happen in India. When there is somebody who can actually, somebody who cannot be disregarded by the health bureaucracy, as it were. But it's not going to happen overnight. But I'm optimistic only to the extent that I think there is a way in which these things can be made to happen.
I'm really curious to know, like, I mean, you said that things can be made to happen. What would you do today, for example, to ensure it happens? Go to court,
I would like to see mental health groups. I would like to see mental health activists go to court on some of these things, saying, or an instance, I'm sure where someone has recorded an advance directive, but where that person's caregivers or treating physicians are not listening to it or not observing it, or when some person is being prevented from nominating a representative. If cases like this could be taken to court, it would help, is my view.
Right. Okay.
It won't happen otherwise, because as you know, the psychiatrist community is very, very conservative, and it was really very few amongst them who really supported the introduction and passing of the current act. Most of them were very happy with the Mental Health Act of 1987, and it just had no time for the new legislation at all. But I think it's not going to be easy. But no one in government is asking these questions, which is why somebody from outside has to ask them. Courts will not ask them so motu. Somebody has to go to court with a matter. And there are, I think, enough mental health NGOs in the country that are quite well placed and well regarded, well respected, who have the authority to be able to take up issues like this.
I mean, is this, in a sense, what you're suggesting is a solution, but at another level, it is also slightly depressing, isn't it? That the only way we will get enforcement of a law in this country is for people to have to go to court.
Tell me something about India that is not depressing. Everything is depressing. But then you still have to fight for it.
Yes, I understand that. I'm not giving up on that. I just thought it's quite sad in a sense that, but I agree with you that most of legislation in our country which has got implemented well has really got implemented because of pressure from the civil society. May not necessarily always be through courts, through many other ways. So the Right to Information Act, for example, or the Right to Education Act, or the Right to Food Act. I mean, many of these things have got implemented only because civil society put some pressure onto governments to try and do something. So that I kind of completely understand and get it. I wanted to ask you a very slightly different question. Knowing what you do, and knowing what you've seen of how the act and the policy has happened but not implemented, and if you were to start this all over again, what would you do differently? Imagine this is 2020. You are the Secretary of Health and Family Welfare, and you have to embark on this process all over again. What would you do differently?
I'm not sure I would be. I'm satisfied, more than satisfied, that what we did correctly. You recall this while you said earlier in the conversation, there were always complaints about the Mental Health Care Act of 1987, but it was not until UNCRPD of 2007,
8,
8,
2007, 8 we ratified it.
that this process was taken up. India did not begin the process of rewriting mental health legislation because of domestic, complaints about what the act said. We did it in response to the fact that we had ratified CRPD. And my sense is, I think we did things correctly. I don't think I would do anything differently. We looked at CRPD. You will recall that initially the idea was we were only going to make amendments to the existing Mental Health Act of 1987. And the first charge on us was to see what sections need to be amended because of CRPD. And you will recall that over January to June 2010, it became very clear that merely amending sections of the existing act was not going to make the legislation CRPD compliant, because the existing act was not in any manner rights-based. And the most significant feature of CRPD and the obligations it placed on national governments was that persons with disability have rights, and those rights need to be at all time respected. So it became, I think the correct decision was taken in mid 2010 that rather than tinkering with the existing act, let us rewrite this process. Having undertaken that exercise, I think we did correctly in from the beginnings. I mean, I forget now how many drafts actually went to the public. We went onto the ministry's website, and how many rounds of meetings and discussions were held. I think which was a correct thing to have done. And yeah, and then you will also recall some stages down the line after you will recall after the bill was moved in Parliament, the very, very interesting debates in the Parliamentary Standing Committee, which again,
Yes.
I believe is a very important part of this whole process. So the short answer to your question is, I don't think I would do anything differently if I was in that seat again, because I believe what we did, our objective was to get in place a strong rights-based legislation that took care of, that understood both the welfare and the rights of persons with illness. We had CRPD before us as some kind of reckoning point, but we had other things. We had our own sense of how earlier legislation had failed, and I think all this put together helped us reach the conclusion that we finally reached in 2017 with the passing of the bill and becoming an act. So I think that process in itself was fine. It's that process cannot be held responsible for the lack of action subsequently.
And if you, I mean, if you were to advise civil society, because which is here, in terms of getting action, you did say one of the things was go to court. In what sort of way do you think, or what should they be doing to even influence policymakers to implement this? I mean, apart from going to court.
I think there's a stage before that. I do believe, I'm sure this is happening, I'm not informed. Any group out there working with persons with illness, I think to ensure that people with illness know and understand what the provisions of the Act are. People with illness ought to know that this is what the law. You recall, everybody with illness and every parent or guardian used to know Section 19, Section 20 of the old Act. It was people who knew almost nothing else about the law, knew that Section 19 and Section 20 could get them locked up. Now, that kind of exercise, people need to understand what the provision of a nominated representative is, that it is indeed legally possible for a person with illness to have a nominated representative who is not a close relative or not a parent or a sibling, that these options are available. I think that I'm sure some groups are doing it, but it probably needs to be done very, very much more intensively, because people will stand up and ask for what they believe is there only if they know about it, and it is communicated to them in a way in which they understand. Now, that is something that should happen. And I think mental health groups should also, through their networks, be in touch with people who may be, if there is somebody with an illness who is being forcibly confined, for instance.
And what would you say to critics who might say that this whole nominated representative and all will not work or does not work because it's completely out of sync with our culture and our family culture, and that's not how Indians are and India is.
No, I would listen to them and I say I don't agree with you, because it's a question of uh, if you were to take that line, and the whole notion of individual rights is something that doesn't sit very easily with Indian culture or Indian sanskar. I mean, the whole notion of individuals being important as different from the family or the community or the caste group is somewhat alien to more conservative minded Indians. So I don't believe that is an argument that should, defeat the purpose of the law. The law does not recognize individual peculiarities. The law is an enabling law. It's certainly not necessary for everyone to have a nominated representative. If they are happy with someone who, in the normal course, in the Indian way, is their representative, and both parties are happy with that, that's fine. But the law enables somebody who is not in that situation to be able to have a representative. And again, the lastly, I mean, this whole business about this is not the Indian way. This throws up the much bigger question of who decides what is the Indian way. I mean, what I think of as the Indian way may not be what you think. I mean, I don't think we should go down that path at all. And people who make that argument, I think, really should be, I mean, they should just be told to listen. Your personal views are not superior to what the law of the country says.
Okay, I'm just looking at the clock and wanted to ask Anand. Anand, is this the
Somebody
point at
asked
which
a
we?
question. Somebody asked
Yeah,
a
go on.
question about clinical psychologists, a subject
Yeah, I
on which
know.
we
So
know everything.
I was
So
waiting for Anand to
Yeah,
ask him if we should start taking some questions at this
we,
stage, or
we
do you want us to
sure,
continue?
we can, but you could also take another couple of minutes to, maybe, if you want to wrap up your discussion part, and then we can get into the
Sure.
questions.
Okay. So I mean, one of the
hang
things
on.
I wanted to go on.
There's one thing I want to say which you have not asked me about. I think, so again, this is where people who work in the space, mental health activists, speak. This question of disability and mental illness needs to continuously remain on the map. We should keep talking about it. Now, you will recall the tremendous difficulty we had at the time of drafting of this legislation, because CRPD meant that both PWD Act had to change and Mental Health Act had to change. And you remember the arguments in which the disability activists were very loud and very vocal. There was no need for a mental health legislation at all, because CRPD said that mental illness was a disability and that we are the disabilities people. And I used to take the position that my personal opinion is that CRPD was written by the physical disability people, and that we should recognize this. And we, in some manner, I think that matter was settled, and the Disabilities Act moved in its way, and the Mental Health Act moved in a certain way. But those issues have not gone away. And I think some work is also needed. What exactly is happening to the implementation of the revised PWD Act? That actually became an act before the Mental Health Care Act of 2017. what is happening to that act, because that is the act that authorizes a medical practitioner to give a disability certificate. That's very, very important for all persons with disability in India. So, as I said, just broadly, I would like to flag that the question of disability and mental illness has not gone away anywhere, and have the fact that we have two laws, both deriving from CRPD, has also not meant that the problem has gone away. It's going to come up again and again, and I think those working in the mental health area need to know specifically what have been the implications of the revised PWD Act of 2016 on persons with mental illness. And has there been an impact? What is happening? Have anything in that act, have any issues from that act gone to court? It's worth looking at. Yeah, thanks.
Just one final question. I think that people in the disability, in the mental health sector, do not actually understand this thing very well. So maybe you can clarify. What happens is that health is a state subject, whereas mental health, or at least the asylums and lunatics, as it is called, is still a concurrent subject. And how does this whole thing work? I mean, because very often what is happening with mental health is a lot of the laws and policies are getting made by the center, but the implementation has to be at the state level. And frequently you hear the central government say, look, we are providing the funds, we are making everything available, but states are not acting on it. I mean, I think for people who don't come from this, I mean, for you, it's just obvious how it will work. But I think if you can just give a quick primer to people, how do these things work, might be useful.
Thank you. It's a good question. And you're right, it is complicated. The Constitution does make certain policy areas the responsibility of the center, certain policy areas responsibility of the state, and some in this in-between category of where both center and state have concurrent responsibilities. You're absolutely right. Health is a state subject, which is why right now during COVID, you see when things become a little difficult, the Central Ministry of Health just washes its hands and says, what can we do? If there are all these cases in Orissa or Bengal or Maharashtra or somewhere, it really is for the state government to handle. We have done what we could, but it is the state government responsibility. This does not prevent the central government at other times from determining health, because it's quite easily done. You see, if the central government is giving you money, as it does under all the centrally sponsored schemes and currently does under the National Health Mission, the moment you start giving money to the states, it gives you a certain position of authority to also lay down. You're laying down program details and you also lay down policy. And to my knowledge, no state government has ever significantly differed from the government of India on any matter of health policy or programming. There may be a very minor example I can think of is under the National Health Mission. Every state in India has an ASHA, but Tamil Nadu does not. So that was entirely within the Tamil Nadu state government's prerogative to have or not have an ASHA. This is a relatively small example. I can't think of a major policy difference. And the government of India has always ensured that state governments have fallen in line through the simple expedient of providing money, because state governments are always broke and simply do not provide in their own budget sufficient money for. So that is one fact. The other important fact is all health facilities belong to the states. The government of India itself has comparatively very few institutions. There is NIMHANS, there is JIPMER, there is PGI Chandigarh, there are the AIMS institutions across India. There is the cancer place in Kolkata. So there's just a few really. The overwhelming majority of public healthcare facilities belong to the states, and they are staffed by state government employees. So the chief medical superintendent of a district hospital and the entire staff of that hospital, the medical officer in charge of a PHO, the nurses, the ANMs, they're all state government employees. It's important to know this because it's Now, what state governments spend on the salaries of all these people, what state governments spend on the maintenance of these facilities, all adds up to how much of India's GDP is India spending on healthcare. It all comes in that 1.1% of GDP. What the government of India is spending on the disease control programs, what the state governments are spending on running and maintaining and paying salaries for doctors and nurses and everybody else. It's all part of that. Now, the specific case of it's one of those oddities that mental asylums are a concurrent subject. The history of that is I'm not immediately familiar with. I'm sure there are people like Sanjeev Jain would know this very well as to why that remained on the concurrent list. But I don't think it makes a practical difference on the ground. The actual implementation of what is happening in those places, whether it is Yarada or Chepauk in India, in Chennai, or anywhere else, is totally the responsibility of the state government. I can't think of a situation where the government of India would override a decision by the state government in a matter relating to the administration of a mental health institution, citing the constitutional provision. It seems unlikely.
So what I'm hearing you say, if I can summarize, you're saying that as mental health stakeholders and the mental health community, if they want to see the act as well as the policy implemented, then really their efforts at lobbying needs to go to state governments, because really that's where the action is.
Certainly, if state governments are able to demonstrate, for instance, after the Supreme Court judgment in the Aravadi case, 2003, it was state governments who had to actually clean up their act. That's a different story of what they did, what they didn't do. Was it a good thing? Was it a bad thing? That's a different story. But it was they who had to do it. So certainly, if activists and groups on the ground, there should be a regular line of communication, dialogue, correspondence with the people in the state governments, the joint directors, deputy directors who are dealing with the subject of mental illness, because they're the ones who know exactly about DMHP districts, how much money is going to those districts, what is happening, and so that needs to start there. And indeed, if any one state under the Mental Health Care Act itself, there are so many actions that the states are required to take. The state does not need to wait for the Central Mental Health Commission to be created to set up the state commission. And it is entirely the business of the state to set up the district level boards. And they don't have to wait for any other state. They don't have to wait for direction from the center. It is their job. And it's probably a good thing for local activists to keep up that pressure.
Thank you. I'm going to hand it over to Anant now. Anant, you were going to look at some of the questions and then maybe throw questions at us both.
Right. So thank you, Keshav and Soumitra. That was very useful to have that dialogue between you. So yes, we did get some questions in advance when people registered, as well as we've been getting some questions on the chat window, as you would have been seeing. So I'll just pick on maybe a couple of questions first from those who had registered earlier. One of the questions which was asked was, how does one address grievances against doctors, especially for practicing something like conversion therapy? Is there a state central machinery? Is there anything under the Mental Health Care Act which can enable people to fight back on that issue? So maybe Soumitra or Keshav.
Okay. Do you want me to answer? I'm happy to answer that one.
Please do it.
I've in the past when I've asked this question too, I've made it very clear that if you look at the Mental Health Care Act, then for all practical purposes, the Mental Health Care Act has a provision in place which does act as a ban on conversion therapy. And it's a matter of reading that and interpreting it. And I'm sure any court will interpret it. Section 106 of the Act says that no medical practitioner shall practice any kind of treatment or therapy which is not approved by the field of their profession. Which means if the psychiatric profession does not believe that some particular treatments are valid treatments, then the practitioner should not be doing that. And if you do that, then in a sense you're breaking the law, and in which case you are now liable for penalties, which can range anywhere from a financial fine to imprisonment. Now, what do I, going back to the 106, not approved by the field of profession. Now, there's very clear statements from the World Health Organization saying that conversion therapy is not valid treatment. There is a statement from the World Psychiatric Association saying the same thing. There are statements from many national professional associations like the American Psychiatric Association, the Royal College of Psychiatrists, and most importantly, recently from the Indian Psychiatric Society, which is an association of Indian psychiatrists, saying that conversion therapy is not a valid form of treatment. So if you take that statement and read it in connection with section 106 of the law, then it's very clear that that is a violation of the act if you find someone doing it. So I don't think that any further legal provisions need to be made. And I think people sometimes don't get it. I always find people asking this. They'll say, why don't you ban conversion therapy? The point is, when you're writing a law, you don't know all the list of things that you might want to ban or you might want to allow. So what you do with the law is you're trying to write a certain principle on the basis of which you can test that principle against a particular practice and say, okay, is this practice meeting with the standards of the law? And then if it doesn't meet the standards of the law, then it's a violation. So that is why, because otherwise, if you just made a list of everything that you want to allow and everything that you want to disallow, then you'll just end up with long lists of things, and which we know in the past has been problematic, because sometimes you might miss out something on one or the other side, and that creates all kinds of problems. So to answer your question, Anant, is that the law already has a provision in place and it can be used.
Sure, great. All right. So maybe a question for you, Keshav. One of the participants wanted to know that, we know relatively the total budget for mental health is sort of minuscule. How can we make the mental health to be a bigger priority to implement affordable qualitative care in schools, colleges, organizations, communities, especially if we would all tend to agree that good mental health is a basic foundation for our country's growth and workforce?
Well, Anant, and your questioner, you have to lobby for this. You will have to adopt various means. You will have to get questions asked in Parliament. You will have to get, if an MP were to ask a question saying, how much has been spent on DMHP in the last 4 years or whatever, is this enough? How much do you propose to spend? How much do you promise to spend? These kind of questions get asked. It would be a way of getting an assurance out of government that this is the way it may not work immediately, but I think it can and should be done. Groups should also, we were talking earlier about, working with state governments. I'm sure if it would be possible to get some state government somewhere to increase their share of what goes into the mental health program. Some state governments may be willing to build it into the National Health Mission Program Implementation Plan, the PIP under NHM, if it includes a mental health component. So it's all a question of lobbying and working on it. It's not going to happen of its own. Allocations for cancer care, allocations for maternal child health, allocations for TB, malaria, to some sense will happen on their own. Allocations to mental health will not. So we need to fight for this, but I can't think of any other way. It has to be continuous lobbying, opinion making, Parliament questioning, and stuff like this. Thanks.
So maybe linked to that is, what can stakeholders do to ensure implementation of the Mental Health Care Act, and also monitoring of the state mental health authorities? There's a question from someone who probably comes from the Northeast, saying that probably besides Assam, many of the other states are not doing much, and that's probably true of many states in India. So what can stakeholders do to ensure that?
It's hard work. It's hard work. They have to group together. They shouldn't fight amongst themselves. They should recognize what the problems in their state are. They should write about it. There should be op-eds in the papers. They should keep petitioning government continuously. They should get questions asked in the assembly. These are all legitimate ways in which you can call government's attention to a particular situation. You could even go to court and say, look, I'm just asking for a proper budgetary allocation to an existing scheme. Please ask government to make the provision. I mean, this kind of thing can also be done. As I said, it's not going to be easy. It will take, they will need proper funding to be able to do this sort of thing. But since they have already come together as, I mean, they are a registered, recognized group working in the area, and they are taken with some respect. I mean, there is no reason why, for instance, the Banyan or SCARF in Chennai, or what Ratnabali's organization in Kolkata, Anjali, why or Mukul Goswami's a place in Guwahati, why groups like this should not, or Sangat even, why people who have a name and a standing and have access to data, know what they're talking about, why they should not just take up issues like this and keep them alive till some recognition starts coming. Let me repeat, it won't be easy and it won't be cheap, but I can't think of any other way in which it can be done.
Okay.
Anand, there are a couple of questions here which were interesting, and I can try and quickly answer them if you want, so that we can get them out of the way.
Sure. Yeah, go ahead.
There's a question from Professor Menon saying that would it be possible to look at farmer suicides and the suicides of 133 migrant workers out of 972 migrant workers who lost their lives during lockdown, and examine if some of them would have been preventable if we had a national network of trained counselors and psychosocial support and mental health service professionals? So I'm happy to answer that, because I mean, we've been talking about this and writing about it. There are two issues here. Because this question makes a couple of assumptions, and I would like to deal with those assumptions. One is the assumption that people who die by suicide always only have a mental health problem, which is not true. Data from India and from abroad shows very clearly that less than 50% of people who will have died by suicide will have a underlying mental illness or diagnosable mental illness. And that's, so suicides is a multi-sectoral, multifactorial issue. So in many cases, just having a mental health service is not going to solve the problem. Very often the antecedents to suicide can arise from place like childhood to adulthood. So, you're looking at a whole range of things that are happening to people, including childhood abuse, which might make them more susceptible to dying by suicide. So I think it's very important that we realize that one thing. And the second thing is also that even if there is mental health problems, even if there is mental illness, the idea that we will be able to prevent suicides by having a network of counselors is a little far-fetched for me, and I'll tell you why I feel so. Is because in a sense the crisis counselor is only a crisis service, and the crisis service also requires a network of the clinical service. There needs to be somewhere you can then refer the person to for treatment and help. Now, if that does not exist, somehow this idea that your crisis service will solve the problem is not going to happen. So it's band-aid. A crisis service is like first aid. Yes, it will prevent and save lives, but if you don't have a hospital to send someone to after an accident, then the first aid is not going to save many lives. So, I think we need to see the solutions to suicide in their totality, both within the health sector and even across the other sectors, including things like employment, prevention of childhood abuse, domestic violence, alcohol use and alcohol misuse. All of these things impact upon suicide. So if we want a solution to suicide, then we need a kind of 360-degree way of trying to address that. And there's enough research from across the world that one single intervention never works for suicide prevention. You need multiple interventions. Those interventions need to be targeted at specific subgroups, and you need to keep on doing it for a long enough time. So that's what I would say. The second question, which I thought I would quickly try and answer, was there was a question from someone saying, how can we, well, two questions. For any kind of violation under the Act, does the bodies mentioned under the Act, possibly the Mental Health Review Board and the State Mental Health Authority, have enough teeth? Yes, they do have enough teeth. Both the Mental Health Review Board as well as the State Mental Health Authority can take punitive action both on individuals as well as on organizations. So on mental health organizations, on health organizations, as well as on individuals or mental health professionals. So they do have teeth. The problem has never been teeth. The problem has been whether two problems. One is that the SMHAs in many states have not yet been notified. And the second problem is that the mental health review boards have not been notified. And the point is that they need to be in place, they need to be trained, and then they need to use their powers to do what they're supposed to be doing. And the second question, which I can quickly get out of the way, is how can we get state mental health authorities to ensure that qualified psychiatric social workers are employed in government mental health institutions? Again, here, the state mental health authorities are supposed to set up minimum standards for mental health organizations, and do remember that government mental health institutions are also covered under the Mental Health Care Act. So they are supposed to set those minimum standards. Now, how you set those minimum standards, because if you don't meet the minimum standards, you can't be registered as a mental health establishment under the Act. So how do we meet those minimum standards, and what do you write in those minimum standards is probably crucial. And then it's equally crucial for the SMHA to ensure that those minimum standards are enforced in the state. So I'll stop here, and then Anand, you can take over, and if there are more questions.
Yeah. So why don't you start, maybe look through some of the comments in the chat window. I'll pick on one question, maybe which Keshav you can answer in the meantime. Now, while you were working on the Mental Health Care Act legislation, what is the kind of pushback you received, and how did you guys handle it? Because it's one of the most progressive health policy, health law legislations we've seen in many. If you compare it to actually many LMICs as well, we don't have a comprehensive, similar law in the public health space. So how did you face, what kind of pushback or opposition did you face, and how did you handle it in a way that you were able to move forward? So maybe Keshav, you can take that.
Thank you. There was literally no opposition within government. Nobody understood why we were bothered with mental illness, but no one stopped me or anybody else from working on that process. And through the process, when we sent our drafts to the Home Ministry, the Finance Ministry, to various places, whatever, there were issues. The legislative department, there were issues, but nothing out of the ordinary. It was always possible to resolve those issues. Where we got pushback was from outside government. First of all, there were the disability people who began, through 2010 and half of 2011, it was actually miserable, actually. The constant argument and disputation with people who thought that our drafts were completely CRPD non-compliant. And so there was a lot of pushback from them. There was a lot of pushback from parents and caregivers who were very wary of who were very wary with this whole business of something being rights-based. And the notion that this person with illness was somehow going to be given rights that were protected by law, and rights which may take away from whatever control that parent or guardian had. It was a complicated and difficult area because they were not badly motivated. They were desperately worried about what would happen to this person in their care who was sick. But certainly there was a lot of resistance. Many parents and guardians had made their peace with the Mental Health Act of '87 and were they were reconciled to the fact that if a situation was a bit difficult, the person could always be institutionalized. And sadly, many parents had just sort of reconciled themselves to that and didn't see why that situation had to change. So there was certainly that feedback. Then there was tremendous feedback from pretty much from all the members of the, I mean, the psychiatrist community in India, especially. Uh, I would say pretty much that very large numbers of private psychiatrists and a significant number of psychiatrists working in government were then and possibly still are very wary of what this law says, because all of them saw it as an attack on their rights. They saw it as an attack on what was, they really had the last say on everything that was done in the treatment of persons with illness up to then. Parents, guardians, caretakers, caregivers, obviously do not know very much and were dependent on the doctor's advice. And it was the doctor's advice that was the last word. So I would actually, at some point, I'd like to find out a little more about how sincerely practicing psychiatrists are responding to the new law in their dealing on a day-to-day dealing with their patients. Has there been a difference in the way in which they treat their patients in the light of what the law now requires? Or are they banking on the fact that their patients don't really know what the new law says and that they can do what they want? But they should know that Section 19, Section 20 don't exist anymore. So, and that institutionalization, when the new law does permit under certain circumstances, that it would be good to know whether those provisions are all being properly followed or not. So that your question was pushed back. So I would say yes, the disability people, caregivers, and psychiatrists. Our biggest pushback were from these three constituencies. Nobody in government cared what we were doing, so there was no pushback at all. So.
Soumitra, do you want to take a couple of questions?
There are quite a few questions which are basically on specific provisions of the Mental Health Care Act, and I'm not very sure that I want to get into that here because this was not a session meant for that. If anyone is interested in that, they can always get in touch with us. We frequently host training programs on the Mental Health Care Act, and if people are interested, they can contact and register for those programs. And these are like very comprehensive coverage of the Mental Health Care Act. So I would direct those questions there. Really, I wouldn't want to. I mean, Anand, unless you feel that no, it's important, you also
No,
answer,
that's
because I
fine.
think that's not what I really think this is for.
But maybe more sort of overarching issues. So one of the issues people have asked about is exclusion. So for example, insurance companies denying insurance to people if
Yes.
they declare that they've been seeing a psychologist or a therapist or a psychiatrist. So in situations like that, how can someone leverage the law?
Well, I mean, my every time that I get asked this by, I get frequently phoned by people from across the country. Somewhere they find out about me, call up, get in touch by email, and they'll say, I'm trying to get insurance for myself, my son, my family, whoever. And the minute we said that there was a history of mental illness, the insurance provider is refusing to give insurance. And in these circumstances, I've even seen the papers. They've actually sent a letter which says we cannot, we are rejecting you because on the grounds of mental illness as an exclusion. And I have always said to people, take that piece of paper and go to court, because you have an ironclad case. You have a solid ironclad case. You cannot but win that case. And if you do that once, if somebody does that once, it will help everybody. But unfortunately, then I'm told, oh, why don't you go to court? Well, the problem is that I could only go to court as a PIL, not as a public interest litigation. And that's of a lower power than if you, the affected person, goes to court, because now it's a violation of your individual rights. And courts are far more sensitive to violation of individual rights rather than PILs, which are just trying to say, well, people are being disregarded. Because I know if I file a PIL, the court will say, show us evidence how many people have not been able to get their insurance, and is that a large number, and all of those questions. But when the individual goes to court, then every single individual's rights are important, and so the courts will take action on the insurance companies. So that's really the simplest and easiest thing to do. And then I know then the answer is, how easy is it to go to court? Well, I mean, we could stretch this argument everywhere. Nothing in life is easy, and nothing in this country is easy. But if we want to see some change, then somebody has to step up to the plate.
Sorry, yes. Thank you, Soumitra. There are a couple of questions around rights violation and what can be done about that. So whether it be the rights of the homeless, who might be people living with mental illness and their criminalization, or it's the rights of those who might have been who are staying in rehab centers, and there are reports of violence and other human rights violation on them, even though there might be SOPs, etc. These are probably not being followed. So what can be done in this regard? So maybe taking that together.
Okay.
Either of
I
you.
think couple of things that you can do. One is obviously lobbying the state government and working with the state government. Now we are working with a couple of governments. In fact, with the government of Chhattisgarh, they've been very progressive about this, and we have now currently run a large training program to ensure that every policeman in every district in Chhattisgarh is trained on their responsibility under the Mental Health Act on with regard to homeless mentally ill people. So, we are actually training about some 150 trainers who are senior police officers, who will then train every single policeman who reports to them in that district. So that's one thing that is required, that kind of training programs needing to be implemented. My view is that most state governments are more than happy if you come up and say, look, we could do this training for you, are more than happy to actually get that training done. So it really does require an effort from our side as civil society to offer that kind of training. And I know many of you will say, well, this is government's responsibility, and yeah, we could keep on arguing about that. It is their responsibility, or we can do something about it. So training is important. And the other thing that you need to also then think about doing is that if you have specific examples of violation of people's rights, then use the law, use the process of the law. So if there is a mental health review board in the district you are in, file a complaint. The law allows anyone to file a complaint on behalf of anybody. It doesn't require only specific people to file a complaint. If there is no mental health review body, file a complaint to the state mental health authority. And if there is neither of the two, the law allows you to go straight away to the High Court. So go to the High Court with that complaint, and in fact, the High Court might say, well, why didn't you go to the SMHA? And that would be a good point to then point out that, look, there are no review boards and there are no SMHAs. So there are means that one can do, which is work with the government to actually get people trained, and also use the force of the law where you can to try and bring about change. I don't know if that answers that question, Anand.
Sure. No, it does. It does. Yes. Keshav, maybe a question for you. A lot of mental health obviously is not just about the health sector. It's about intersectoral coordination. It can also mean working across departments or ministries. You have social welfare, disability, education, women and child development, education, etc. How do you ensure that there is intersectoral coordination in a way that we enable mental health rather than have a tutu BMI kind of situation where people are just pushing the envelope to each other and not doing anything about it?
Anand, this requires people who are prepared to work. The system will not take care of it. Whether at the level of the district or the state government or Nirman Bhavan in Delhi, you need to have people pushing this process who understand the need for kind of harmonious coordination, as it were. I believe this sort of coordination happens routinely certainly at the district level. For instance, I'm fairly sure that there is quite close coordination between the health people and the women and child people, just to give another example. But my short reply, therefore, is you will need somebody there who understands and recognizes the importance of this sort of coordination and gets it done. It won't happen of its own.
Sure.
Yeah,
okay. Um, Soumitra, there is a question around the fact that we know that if people with mental illness, some categories like people with psychosis, if they're given treatment early, it can help prevent complications. But if a person refuses treatment but is not violent, is there a course of action under current law? I have a view on this, but I would rather have you say.
I mean, I would like to widen that question, because I think very often how you look at the question also determines the answer. I think the broader question is that we need to ask ourselves that people need early treatment, and if people need early treatment, then is there a provision for early treatment? And secondly, if there is a provision for early treatment, then why are people refusing that early treatment? I think that's really the question that we need to be asking before you jump into the situation of does the law have a provision for it. And I think sadly both those questions are in the negative. Is there provision for early treatment? There isn't. Very few public health programs in this country actually have an emphasis on providing early treatment, or identifying people with psychotic illnesses early enough. Our mental health system is still only reactive, not proactive, so that it waits for people to become ill enough to come to them, either directly or through their relatives. It doesn't go out and try to look for people who might have a problem and try to help them. So we're not being proactive in a public health manner that you would try to do. We wait for people to fall sick and come to us. So I think that is a problem with the way the health system is designed. And the second issue is that if whatever services are there, if people are refusing services, then really we should be asking why people are refusing services. And the simplest and standard answer to that very often is that services are being provided in a manner and in a location and in a situation that is just not acceptable to people. I mean, I frequently ask people, would you be happy to be treated in this place? And if the answer to that is a no, then why would you want somebody else to agree to be happy to be treated here? You see, very often refusing to be treated at a certain place does not necessarily imply that you do not understand the need for treatment, but that you tell yourself that this is not the place I definitely want to be treated at, given the kind of treatment that you're going to get there and the situation of the treatment and all of that. So, I think we need to answer those specific questions. Internationally, if you look, there are lots of programs which try to engage with young people for early treatment. There are a lot of alternative treatment programs which have now come into place, which work with young people early enough and have excellent results, by the way. So I think there is also a need for us to get out of a mental paradigm that every time somebody says no, how can we force them to take treatment? I mean, I think this kind of a conceptualization of the world also needs to change a bit from that. And not everybody who is ill refuses treatment. I would imagine that out of the millions of people who have a mental health problem in this country, there would be a tiny majority of people who refuse treatment. And in that tiny majority, many of them would have reasonable grounds to refuse treatment because of the quality of the treatment or the kind of treatment being provided. And that would leave you with a tiny minority of people who genuinely, for whatever reason, need the treatment but are refusing it. And in those cases, obviously, the law makes provision for that. But I think we need to see the whole thing in a totality rather than just jump into this. What are we doing about this? Otherwise, it's a case of the tail wagging the dog. It's a tiny tail, and we can't allow the entire dog to be wagged by that tiny tail. So I think it's important to also pay attention to why people are saying no. The lack of services, the lack of quality of services, the lack of acceptability of those services.
Kesha, we're going through a pandemic, and obviously, like it has impacted all aspects of the health system, it also has clear implications on mental health. So, from a policy perspective, any thoughts you might have on, what the impact on mental health through the pandemic? What can we do to sort of bring that to the spotlight? How can we advocate with policymakers around that specifically within the larger picture?
Thank you, Anand. Just 2 points come to mind. One is There have been reports that this whole process, loss of employment, being confined to home, having to return to the village from a city, and the lack of income, there has been, this has definitely contributed to, uh, you know, illness of one sort or the other. I've even seen a report which looked at figures of attempts at suicide, comparing figures with the current year compared to the same period in the last year, and showing increases everywhere. So certainly people are beginning to look at this. People seem to understand that this is happening and are looking at data and bringing it. It's certainly something we need to talk about. Also, the other thing I'd like to say is that it is unfortunately not many people with mental illness depend entirely on the government's medical system for their medication. But where such people do exist, they have probably not got their medication, certainly for a few months through lockdown. Because I mean, we have heard this about TB patients depending on dot supplies. We've heard this about diabetics needing their insulin and other medication, and uh, almost certainly this has also happened to persons with mental illness. But then the numbers of persons with mental illness dependent on a government source is probably not very large because of the poor performance of the government source to start with. But it certainly that they have not that they've been denied whatever attention they would otherwise have got in their own situation. I think that is true, and it is something that we will learn to have to handle once the worst of the pandemic is over and something resembling normal interactions have begun again. But it's an important point. Yes.
Sure, thank you. Now, Saumitri, I think you spoke about this earlier in the webinar as well, and you've also, highlighted this on social media, this whole issue around helplines and, how they might have limited utility, obviously, and that's not the only response you can have for anything from suicide prevention, etc. But also we're seeing a lot
Oh,
of new technology innovations, no chatbots,
I
apps,
lost you for a
etc.
minute, Anand.
Sorry, I was saying that you've talked about helplines as an, as an example of, it is in isolation not going to be a comprehensive solution. But then you also have the chat boxes, the apps, and various other technological innovations. Do you have any opinion around, their role and effectiveness in mental health space?
Well, I do see technology as having a huge potential in mental health. Okay, that I have no doubt about. And at various aspects of mental health, so in terms of training, in terms of all sorts of things. But I equally have a lot of reservation about a lot of the quick fix apps that have come out into the market, and the reason is twofold. One is that there is almost no data on the effectiveness or the safety of these apps. Most of these apps have not gone through rigorous testing for either effectiveness or safety. And the second thing is that, and in the context of the fact that they actually charge people because they're paid apps, that creates a problem. And many of these apps try to get out of this situation by trying to claim that, well, we are not providing a service for people who are depressed or who have a mental health problem. We are only providing effectively a wellness service. So while they say that, and that's the disclaimer they'll get you to sign, they are advertising and they're pushing or positioning of the app is as if it is a treatment for a mental health problem. And so this is driven largely by commercial interest as opposed to in terms of trying to help people. So I have a big worry about the fact that these apps are largely untested, and most of these apps are consumer facing apps which are in the market. You can download it from Google Play and then pay a small fee and you'll be able to use that. None of these apps, or almost, I know of very few of these apps which have gone rigorous testing. I mean, for me, the issue is, would you allow a medicine on the market if it had not been tested? And I know you probably say in the COVID situation, we've seen that happen. but broadly enough, you wouldn't allow any treatment on the market unless it had been rigorously tested, both for effectiveness and for safety. Why would you allow that just because it is technology? Why should that be any different a rule? Because this is about human lives at the end of the day.
Great. We are well out of time, but I think I'll give a minute each to both of you for closing comments. So Soumitra, first you, and then Keshav as the last word.
Well, I don't have any closing comments, and thank you so much for inviting me. Thank you for this wonderful questions, and thank you for everything. Thank you.
All right. Thank you, Keshav.
Likewise, Anant. I'm glad at this discussion. I'm glad there is interest in the subject of the policy and the act. And it is this interest I expect that is going to have to see, more positive actions resulting from the fact that we have this act and this policy. Thank you.
Great. Thank you so much, Keshav and Soumitra, for joining and for providing your insights. Thanks also to the teams at Sangat and the Center for Mental Health Law and Policy for helping organize this event. And a special thanks, obviously, to all our participants who joined and listened in and asked all of these very useful questions as we all try to figure out better ways of making mental health care accessible in the country. Please keep joining these policymaker engagement webinars. The information is shared through our social media channels. Please take care, everyone, and have a safe weekend. Bye for now.
Thank you.
Bye-bye. Thank you. Bye.
Thank you, Samitra. Thank you, Anand.
Take care. Bye.
Thank you again. Bye-bye.